Welcome. Thank you for coming to our panel. It's AgeTech Industry Challenges and Opportunities. I'm Erin Marizella. I'm the Executive Director of an organization called Innovations in Aging Collaborative based in Colorado Springs. Has anybody here not heard of AgeTech before today? Okay. So for those who are not familiar, you probably can deduce that AgeTech is technology that serves the needs and opportunities of aging. So why AgeTech? So Innovations in Aging Collaborative, we're a government consultant, and we work with communities to help them build themselves so that people don't fall through the cracks as they age. So I need tech solutions to be effective in what I do, and I have done health tech coaching along the Front Range with health tech startups, and people often tell me that anyone can use their product. It doesn't matter how old you are. But my constituents tell me that is actually not true, and sometimes your age impacts how effectively you're able to use a solution. So what I am hoping for is a really vibrant age tech ecosystem in Colorado so that we can develop the solutions that we need here so that people can age in place and use the bus and go to a yoga class and connect with their families no matter where they live in Colorado and the United States and the world. So I love age tech. It really helps me in the work that I do, and I'm hoping starting today we can elevate the industry in Colorado. Before I get started, a very quick word on ageism. The World Health Organization defines ageism as, I have to read it, sorry, it's not memorized, stereotypes, prejudice, and discrimination towards others and ourselves based on age. I'll leave it at that, but I will just say that if you plan to work in age tech, I highly suggest that you check out Changing the Narrative and check your own biases on ageism, because it's prevalent, it's in all of us, and it's one of the isms that we don't talk about a lot. So there's a fabulous anti-ageism group based in Denver. They're called Changing the Narrative, and they're leading the charge nationally on changing cultural perspectives on aging. So I've already introduced myself. I'm Erin. I'm in Colorado Springs with Innovations in Aging. I will have our panelists give us a quick introduction and tell us your expertise in the age tech industry.
Now it's working. Megan. Okay. All right. Hi, everyone. My name is Danny Kaplan. I am a co-founder and general partner at a venture capital firm called AgeTech Ventures. It stands for Health, Equity, and Age. We actually just announced our firm basically today. In the past and still for several weeks, I'm also an investor at a firm called Generator Ventures. We are a seed and Series A investor, focused on the intersection of senior care and technology and healthy aging. I've been working at this intersection of senior care and tech for the past 10 years. Worked as an operator at a company that made web-based software for home care agencies. Found my way to grad school, got an MBA, and got an MS in gerontology, which is all about senior care and aging. The regulatory side. Interned at Generator for about a year and a half in grad school, and then joined on a full-time basis June 2019. And our focus at Generator and at AgeTech as well is in tech and tech-enabled services, B2B, B2B2C. We're primarily kind of healthcare investors, but I like to say that we invest in senior care, so kind of the medical side, and aging, social side.
Is this working? Hello, everybody. My name's April Krutka. By background and training, I'm a hospice and palliative care physician, still practicing. Early in my career, I was a through and through clinical, well, I still am a through and through clinical physician. In every practice that I joined, whether it be a hospice agency or a palliative care program, at that time, palliative care really was kind of the new cool kid on the block, and everybody wanted a program development, and I learned by developing larger and larger programs, consultation service in level 2 trauma centers and integrated health systems that serve 50% of a state or multiple states. I tech-enabled those services, built, staffing models, all the workflows, everything that was needed to make a care delivery program run. At about the 10-year mark, I had a severe case of what I would call compassion fatigue, trying to help people in a completely broken healthcare system, and I literally got to the point where I was grieving every day going to work, just seeing the same story over and over and realizing that our saying as physicians, how do you change the world? One patient at a time. I started realizing it wasn't true. And that's when I moved into the business side of healthcare. I worked for a regional payer and led a demonstration with the Center for Medicare and Medicaid Innovation. It's called the VBID Benefit Hospice Component Pilot, where I really got to dig into regulation, what innovation in healthcare really means, built identification and stratifications to make sure we were identifying the right members at the right time. And that was a 3-year project. And now I do consulting with venture capitalists. I'm the fractional chief medical officer for Centered Care, which is technology-enabled services and a platform purpose-built for senior living. So providers, operators, and seniors who choose to live in senior living communities can thrive there and get high-quality care.
Hi, my name is George DeWare. I'm the president and CEO of AgeTech Medical. One of the things about ageism, I also founded my own narrative. I'm working with students who just graduated, well, they graduated from college in 2019, and I would refer to myself as the old guy that they brought on. That is no longer what I can say about myself. I'm the experienced person. I'm the gray hair that they brought in that has done things. I have been an entrepreneur. I've been in corporate environments. I've been part of a company that went from a startup to an IPO, from a roll-up to the pink sheets and to the NASDAQ. I was general manager of e-business for a HBR case study in failure, Eastman Kodak. I was the change agent that was brought in to bring in e-business principles, and their level of complacency did not allow them to listen. So unfortunately, 100,000 people lost their jobs. All the shareholders lost their value. But failure is a big part of any kind of startup and learning from those kinds of mistakes. So I've had several different kinds of business experiences. I was a mentor at Boomtown Health Tech, which is where I met the young entrepreneurs who had invented the capability of placing sensors on a walker that measures how much weight is being placed on the handles and the distance of the hips from the frame. So if you think of people using walkers and you see them hunched over, in real time we are able to provide biofeedback. It's haptic. It's your cell phone on vibrate, and an LED changes from green to red. And it's an alert that helps train people to walk better, because we're all about safety. And it became, the founder started it because he saw his grandmother falling out. And so we started out of a fear base. I've much more now changed that to quality of life and the joy of living that we can help people who are mobility challenged to have and be with their families and their friends. That's me.
Hey everybody, I'm Ed Likovich, CEO of Nimble. Our purpose is to help older adults not fall. My background's actually in experimental physics, which is kind of weird when you think about health tech, but that's how I got here. But really our focus is on delivering a digital solution to older adults that basically gives them a daily exercise program they can work through to help prevent falls. The way I got here is through my grandfather. So my grandfather was an immigrant to the United States. Really the American dream story. Came and settled in the middle of nowhere, Pennsylvania, built a thriving small business in the steel industry, for those of you who are old enough to remember that time here. And he was in his early 70s and had a really bad fall. I was 10 years old, and I remember when it happened. And he fell off something that was pretty high up, hit his head, got a TBI, messed up his knee, and it was 2 years of being bedridden. So he went from being this vibrant entrepreneur at 71 to somebody who never got out of bed again. And I got to see that as a 10-year-old on to being 12, and he passed away when I was 12. And that sort of thing sticks in the back of, and I think a lot of us probably got into this world because of a similar story. And so seeing that was sort of tucked away. Fast forward through physics and some weird stuff, and now here I am in Denver, starting a company to help people not fall and to help people not have the same story I do with my grandfather. So that's my quick background. This is a bracelet my daughter made for me. She told me I needed to wear it today, and she said she made it really, really big so it would fit on my hand. So in case you were wondering, that's what that is.
Excellent. It's an intergenerational panel, after all. So, thank you all for introducing yourselves. I will start with a question for the founders here. So, from what I hear from people who are starting companies, any kind of company, and from what I tell people about what AgeTech is, we're not selling toothbrushes, right? It's not just a toothbrush. It's something that changes people's lives. Arguably, if there are any toothbrush people here, sorry, they're also good and important. But from where you sit as a founder, as an AgeTech founder, what are the key challenges and opportunities that arise from the uniqueness of this industry?
First. Can you hear me? Hello? Okay, there we go. I think from a high level perspective, so our platform, our goal is to enable a lot of other technologies to change outcomes in a specific population. And one of the things that it's a very frothy market right now. We have 2 fall startups here with us. So I think one of the challenges that I see is there's so many great ideas. And when technology enters the healthcare space, they are entering a complex matrixed ecosystem. And just very general questions that we're used to being able to answer in healthcare. Like if you say you decrease falls by like 30%, I'm going to ask to see the data. And then if we get far enough down the line, I'm going to ask for your data set. And I'm going to run the analytics myself. I mean, that's kind of the standard expectation on the payer side of the house before a payer would ever partner with you to give a service to their members. And so I think one of the biggest challenges is when you're stepping into a new ecosystem, making sure you understand, I feel like I'm asking simple questions sometimes as a clinician and somebody who's worked for a payer and done a bazillion RFPs for a payer. But sometimes we speak different languages or have different expectations. And even though at times I will see a solution that I'm like, oh my gosh, this could change everything, to be able to get it to where it needs to be and get it the access and distribution it needs to be within the healthcare ecosystem, you have to start from a place of a contextual understanding that may be outside of your own. And I see it, that's a huge barrier to me because healthcare is complicated. I've spent part of what I'm doing right now is jumping to all different parts of the healthcare ecosystem so I can start to really put together, how do we fix this? And so I think that's one of the biggest challenges that I see.
I would echo everything you just said. So we have hardware. So first of all, it's hardware. Hardware is hard, right? It's a pain, and it takes many iterations, and it's very capital intensive. So take that. Then I have to get data, and to get clinical data requires multiple test subjects and additional funding. And we did pilot tests, so we do things. We're bootstrapping basically. But the data, the efficacy that we've gotten, but only with an N of 15, doesn't really get you to the point where the payers are going to pay attention to the degree that we would like them to. We know that this thing works. We know that it does work with the multiple pilots that we've done. I think we've got 80 now. But we're still not to the point where we can get into an NIH kind of arena. So the validation of hardware, then the efficacy of it, and then getting testers. And when the founders, they won the New Venture Challenge at CU in 2019. They had a lot of momentum coming out. COVID. Can't go into senior living communities for 2 years. So we spent that time refining the hardware and making sure that we had all that together. Now trying to come out of COVID and try to get that momentum back is a bit of a challenge to get the volume. You've got a different story with that.
Yeah. No, I'm pretty optimistic on this. I think when I look at the older adult tech market, older adult health tech market, I think it's hard to find a better market out there. I think you have a growing population I think you have a wealthy population, and I think you have a population that's been traditionally underserved and forgotten. And I think the world, especially the payer world and the healthcare world, is starting to pay attention to that right now. So I think that this is a great time to get into this market. So I think that's my optimistic side of it. I think there's two things that I would say that are technically challenging about this market. The first is that a lot of other this functions the same way. You have to provide value to somebody who's willing to pay for it. I mean, that's the fundamentals of any market. And I think that this functions similarly, with the exception that there's often multiple stakeholders in the mix here in the older adult market. We sell, for example, to health plans, and then we distribute to older adults who are on those health plans. So you have another person in there. We're sort of B2B to C. And it's rare to find, at least in my experience, a successful older adult business that's going direct to older adults in a direct-to-consumer way, because that direct payment mechanism just kind of isn't there yet from an acceptability perspective. I think the other aspect that I'd come back to is similar to what you said, is around measurement. And we talked about outcomes a little bit, but I just want to hone in on measurement. Like getting a partner on the other side to agree to measure something in the same way that you do and agree on what the shared value of that is. I mean, we spend months on that, and we still don't get it right with a lot of our health plan partners, because we'll measure this, they'll measure it, and we'll come together and they'll say, hey, you saved us money. Great, yeah, we did. And then we'll argue over how much, because they measured apples, we measured oranges. And I think that's, if there was a piece of advice I'd give to a new older adult digital health AgeTech business, it's figure out what your value is and really figure out how to measure it in an unambiguous way, because that's what holds a lot of people back. You measure something, you don't agree on it, now you're another year to repeat that and remeasure it.
To build off the point too, who are you communicating with? It's not necessarily the older adult. The sandwich generation it's not only their children, it's also the grandchildren. And those are the folks who are more likely to spend. We do B2C as well as B2B to C. And the direct to consumer side of this is actually a little bit easier, because adoption rates in the industry are slow. That was technical. All right. Sorry, at the last rave, I don't know. So the ability to communicate with those markets and to understand how, and it's an emotional pull that we're trying to communicate, and the value, because the other piece of this is we're trying to prove the null, that we're preventing something. And that's always, what's the ROI? But if you're saying you're going to prevent falls, it should be something that we should be able to quantify.
There's all kinds of lawsuits happening about the data and trying to prove something that you made not happen. That's really hard to do between a health plan and a vendor. But, we shouldn't have started this with me, because I'm a hospice doctor and I'm always like, But I'm really a happy, excited person in general. But I want to build on your positivity and say I'm really excited about this talk too. Healthcare desperately needs technology. I literally still wear a pager sometimes. Like, that is no joke. And we still fax things. And our EMRs, everybody knows this, we can't barely extract data out of them. And so it's just, and we, let alone like automating really good care for people, like workflows. And like, I personally think doctors should not be the gatekeeper of all care anymore. It's 2023. If we know somebody needs something because we were able to get the right data points in the right place and stratify them, then they should get it. We shouldn't have to like make them go see a doctor and a doctor think about, like there's certain things that, yes, we should do that. We desperately need to be modernized. And so, we need all the tech people we can get, because what we got ain't working.
So this moves really well into the question that I have for Danny on the funding side. So when we're talking about how we measure, what is the return on investment? Like, what does measurement look like? When you're looking to fund age tech companies, what statistics do you find credible that are outside the typical financial metrics that are relevant to age tech? What do you look for? Like, what makes an age tech company look like a good investment to you?
Great question. I think start off by saying that we don't invest in early stage companies. We invest in early stage teams, and teams are made up of people, and we invest in people. We look and I would actually not even say that we invest in people. We partner with people. And, when you're talking about, funding a company, funding a team from seed or from Series A, through to whatever, the eventual outcome is, you're talking about a partnership that's, 5 to 10 years. So, I think first is the airplane test. Would I want to sit next to this person on an airplane for 5 hours, right? Because we're going to be sitting in the boardroom with them for a lot longer than that, for many years. So, I think the first thing that we look at is definitely people. Second, as kind of more predominant kind of healthcare investors, we're definitely looking at like what the go-to-market is. And we look for companies that flat out measure things. Actually, Ed at Nimble, he was one of the first founders that I spoke with. I don't know, I feel like back in like 2019 or something, where where kind of I spoke with him, and he's like, our company's about falls, and I'm like, yes, so is everybody else's company. And then he goes into like how they're measuring things and how they're tracking things and the data that they're collecting. That's just checking a box right there, right? And of course, I want to go in. I want to know about claims. I want to know about outcomes, right? One thing that kind of when people go to contract, especially with payers, and I've had this conversation with founders a lot of times, just in the last couple of months, is founders are getting opportunities at the earlier stages for payer pilots, and that's really, really, really exciting. And what happens, the founders, especially for technology-enabled services companies, which are typically delivering care, are placing some kind of intervention. Because they're doing that, they're creating a lot of value for their customers, typically the payers, meaning they're saving them a lot of money by ways of reducing medical costs. And so what I look for is I look in those contracts that they have with payers, and I want to see that founders have negotiated to get claims data for the population that they are having an intervention with. Because with that, they can later go back to that payer and ask for maybe a portion of that shared savings, or raise their prices and have a good argument for why they're able to do that, or anonymize that data and go say to another payer, we're saving, these plans in Colorado, XYZ dollars per patient per month. And so I kind of look for founders who are being really smart about the data that they're collecting, not only when they're working with patients, but also when they're working with customers. I think kind of on like the social impact side, we'll definitely look at like, does this product help with or help reduce turnover in a facility? Does this product reduce the number of times that a person is being sent to the hospital or readmitted? Right, so like, all of that stuff is very important. What I'll say at the very end is just, all companies are different. So, there's kind of like high-level checkboxes, high-level things that we look for, but it's hard to say that, oh, well, your company, you don't check these boxes, right? Well, maybe they're not a box-checking company. Maybe it's a circle-checking company, right? And so it's difficult to have a general kind of attitude of this is what a company should have and this is what it shouldn't have. I think all revenue isn't created equal.
Thank you. That what you said about asking healthcare companies to split the savings that are gained from using this technology, I think that is, we need to ask for access to that data. You're exactly right. Because I've heard that, like, what's it called? Medicare Advantage plans will pay for, some remote patient monitoring service maybe. And it's part of the plan. But then the people who have provided the technology for this remote patient monitoring, they have no idea how many people are using it. They have no idea the benefit to the company. And so they have no way of showing, because they have a, fee for patient, they're not seeing how much the company is saving from that on the back end, so it's hard for them to scale. and make an argument for scaling in other areas. So
It's such an important, we collect data on our users with their permission, obviously, and it's not anonymized, right? HIPAA and all the fun things that we have to be very careful about. But we collect data. It's so vital to have impact and outcomes. And our CMS is now providing reimbursement capabilities for remote patient monitoring and remote therapeutic monitoring. And these kinds of things, it ties in with our model in that with the sandwich generation, we can tell you if grandma's moving, if she's not moving, and how well she's doing, or progressing or not progressing. We can also provide that information to the healthcare provider so they can inform their care. There are also soft pieces of information. We're not diagnostic, obviously, but we can provide information like suddenly we saw a spike in activity at night. Well, what's the reason for that? Is it wandering? Is it restless leg? Is it a UTI? And what kind of things that you can do to interdict other healthcare issues that may come up. So the collection of data and being strategic about that data collection is vital to multiple different revenue streams and also value of the company.
I want to add to that, though. So I worked for a regional Medicare Advantage payer. And what I would say is when you're negotiating with a Medicare Advantage payer, you can make, like, I used to work with vendors because it was in our best interest that a vendor like yourselves is successful. Like, we don't want our members getting sick, and if there's anything we can do to help prevent that, we're willing to invest in it. But you also, when I say understand the context of healthcare, what part of the ecosystem you're in, you have to understand Medicare Advantage plans are used to claims data, which is episode-based. But we all know health doesn't happen in episodes. We all experience our health every day at every minute. So before I even would start talking to a Medicare Advantage plan, you have to approach this knowing they are really good at analytics and data, claims-based. But if you start giving them data outside of a traditional, they'll probably be excited about it, and there'll be some champion in the company who wants your product and wants that data and wants to do something with it. But it's going to be up to you to prove the value and how this can change the whole paradigm in their data model. Because they're not going to probably have a model to do anything with that data that you've had before. Patient-reported outcome measures, remote patient monitoring. How do you put that into the context of the claims analytics that they're usually doing? They have limited amount of clinical analytics. So I would say at the same time, this is where start those discussions early and look at where can you overlay your data in the claims data and match them with the same members and start with a pilot so you can get that process down in the first place. I mean, that needs to be part of your scope, right? That you scope out in the beginning when you're doing the contracting. So I would also say, sometimes I'll hear startups and I'm like, oh my God, you're gonna change the whole world and it's wonderful. But then you start putting it into the context of healthcare operations and you're like, yeah, we're in third grade here and y'all are in college. So let's see if we can get in the same grade first and bring your ideas. It has to make sense in the context of how we do it today so we can take a step forward together.
Yeah, I'll give you a quick story on that. Is, you know what our health plans tell us? I mean, we collect data on everybody. They say we don't want it because of the liability. If you send us data and it shows something and we don't act on it because we're not capable of receiving it, we don't know what to do with it. We don't want it. So that's the third grade mentality that we're in. We came into health plans thinking, oh my gosh, Cigna, Humana, all these people we work with, they know what to do. They have no clue. They have no clue. You have to come in and you have to tell them what you're doing, what matters, here's what we're measuring, here's why it matters. You have to be much more prescriptive than we ever thought. It's not as simple as just dumping data and hoping they're going to figure it out.
Yeah, and put yourselves in their shoes in a minute. I get why they're saying that. If they don't have operations to respond to something that they found out happened yesterday, you can get it. Why? So it may put them at risk. If they know somebody fell and broke their hip and they didn't do it, well, it's not their payer's responsibility to do something about it. But anyway, they just have to pay for the stuff that happens. But so you put themselves in your context, in their shoes. I get it. And so you always assume good intent in these conversations. Understand where they're coming from. I can't tell you, there are really good payers out there, and then there's ones that are really hard to work with. And you're like, how do you even sleep at night? I always walk into conversations assuming I'm talking to the good guys and girls. Always do. and then try to bring your context to the table. But these are like multi-year projects we're talking about, so it's a lot of work.
And that's on the strategic level, right? The inability, on the tactical level, we just had a pilot that ended, and you could call it a failure because they didn't buy and they didn't use. But the problem was they didn't put our product into their slipstream of how they treat in physical therapy, in short-term physical therapy. There's a script, and they were not going to deviate from the script because they're booking half an hours with 10 minutes on either side, and they only have a short period of time. They're not going to take the time to learn and train on something new. And the people that were looking at the unit, the PTs that we were working with, like, this is fantastic. We love this, but I don't have the ability to fit it into my care stream.
I think we were talking before the panel started today. George and I were talking about the perverse incentives of healthcare. And when I started as a healthcare provider, I had just, rosy lens of I'm going to help people and I'm here and I'm going to get all the resources and all the time and I'm going to save all the lives. And your hands are tied often. I like what you said, April, about, we have to think about where people are standing. That makes total sense. Like they don't want to know that someone fell yesterday and they didn't have staff to address it. And that concept came up a lot when I was working in senior care. Ed, you mentioned, I think you made a comment early on about the amount of money that older adults have to spend on tech solutions. And we had a conversation about that earlier this month. And Danny, you made a comment to me that really stuck with me, that even though, when we talk about AgeTech, we talk about America will spend $7 billion on AgeTech by 2030. That's not everybody. Like the people I served in rural nursing homes, those are not people who are going to spend $30 extra for a tech solution to help themselves, to help their parents. They don't have that kind of money. And a lot of the older adults who I served depended entirely on Medicare and Medicaid for their healthcare needs. So when we're talking about who your real customer is, I see a lot of people saying yes, like the people in this room, your customer is not actually the 80-year-old woman who you're serving. Your customer is Medicare Advantage plans, their children who are helping to build their lives. So that depends on those stakeholders investing in your product. So, Danny, can you share with us a little bit about how you see AgeTech fitting into this, the incentives of healthcare, and what the opportunity is?
Yeah, absolutely. And I think that, just to qualify what Ed said, I think that he brought up the whole income and disposable income piece in his kind of optimistic view of the market, right? And we all know that there are wealthy individuals of all ages out there that can pay for a variety of things, right? So this is kind of like the conundrum of investing in this market, right? Is that there's 12,000 people that turn 65 every single day, and by 2030, every boomer is going to be age 65 plus. By 2050, I think it is 40% of every federal dollar spent is going to be spent on older adults. That's more than the defense budget. That's insane. Just think about that. So there's a lot of money out there, right? But everyone up here is talking about health plans and Medicare Advantage and Medicaid. No one's talking about going direct to consumer, right? Now, if you think about Medicare Advantage as a consumer product, which it kind of is, right? So I think maybe 75% of MA plans don't have a premium, the rest do. So about a quarter of folks on MA, and there's about 51% of Medicare beneficiaries get their benefits through MA. So Medicare is effectively, most of it is privatized now. A lot of people don't know that. So if you think of it as a consumer product, it's a pretty successful consumer product, right? But they really aren't paying for it. We are. Taxpayers are paying for it. Senior living is another kind of, it's a consumer product, I would argue. But when you go and you look at the breakdown of income, and I was literally just looking at this data a few weeks ago from the most recent census. So let me because I'm not that good at stats. The mean income of someone age 65 plus, I think it was like $76,000. That's not that bad, right? The median income, the middle value in that data set is $46,000. It's a pretty big difference. And the thing that I compared it to on the Genworth Total Cost of Care calculator, which is really neat tool, I said, what does the average across the whole U.S., the average kind of 1 year of assisted living cost us? It's about $54,000. So I was just talking about income, that's pre-tax income, but that $54K for AL, that's post-tax money. So I think that when you talk about building a really big, impactful business in AgeTech, one that serves older adults, one that serves families, this is a volume play, and you're talking about building products and services for the middle class and for lower income folks too. So I think that that's one of the things that's really held us back, is that there are these amazing products out there, but the go-to-market is so tough.
Well, let's add a strategic lens to that, because I think this is really good, and I want to be really supportive. I think for a tech startup to focus on the higher end of the market is really smart. There's less barriers. They're a healthier population. You'll get higher adoption rates. It'll accelerate your timeline. But if you're talking about working, like trying to contract with a payer and get shared savings, that's going to be the least amount of shared savings revenue in that market that you're going to be able to generate. The further you go down the income perspective, the larger amount of shared savings you're going to be able to generate. So if you think about it from a strategic perspective, like I think that that's a great go to market. Like, let's start in the higher segment of the population, get the kinks worked out, get some customers, get our feet on the ground, generate some revenue, raise some funds. But then if you want to start going to payers and you haven't started tiptoeing into the middle market, because you're going to have all other sorts of barriers in that market. They're going to have less access. They're going to have worse health care outcomes, which is what you're trying to help Medicare Advantage with. And so they're going to have more falls. They're going to have more gait instability. They're going to have more complications from falls and fractures and just rapid decline after the fall. And they're going to have less access to health care. So if you think about it, that's one way to think about it. There's a lot of people out here that are way better than the clinicians sitting up here about strategy and go-to-market and all of those things. I'm not an expert. But I just wanted to add that strategic lens to connect the dots between what you two said.
Yeah, I think one of the big promises here is what digital technology offers to an older adult population that's becoming increasingly technologically savvy. I think a lot of our services in the past have been in-person based, and that leads to that economic divide. It leads to a rural-urban divide. And one of the things we've been most proud of is what we've deployed throughout the state of Colorado. And if you look at the percentage of people just on a demographic basis who are urban, suburban, rural, and frontier, our enrollees and participation in our program exactly matches that histogram, meaning we're reaching those frontier and rural people at the same rates as we're reaching the urban and suburban. We wouldn't be able to do that without a digital technology. And by the way, a digital technology that doesn't require streaming. There's a lot out there that requires broadband access. Broadband access is not out in the rural and frontier areas. And so I think that coming back to kind of this optimistic thread, I think that we have, in post-COVID, the older adult demographic has become much more technologically enabled, much more capable of consuming these digital technologies, and they want them because everybody wants to control their health. Everybody does. We assume older adults don't. We assume they want to be told what to do. That's completely not true. And so I think that there's a huge opportunity for digital to come into the home and to help older adults on their own pace, wherever they are, be able to access the healthcare they need.
One of our first test was in Cherry Creek, and then our second test was at a HUD-based senior living community. And the differences and the deltas were amazing. We really made huge impact on the folks that were at the lower socioeconomic side. And it was incredibly encouraging. It also helped, it really had to inform our how much we were charging for our product, because suddenly the disposable income was not there in our price point, and the COGS that we suddenly had to adjust that because I've got to now get to a volume base in order to make it affordable.
A couple of you mentioned right now the difference between rural and urban and access to healthcare. And when we talk about rural areas, people are typically older, sicker, and have less disposable income. So is this group, are we all from Colorado? Are we Colorado people here? Have you heard of the digital equity program coming from, yeah, smiling. So the state of Colorado is working on a digital equity program right now. And Innovations in Aging was one of the surveyors of older adults throughout the state. And the question is, do you have broadband? Do you have a device? And do you know how to use it? And when I've talked to companies in the past who are building health tech solutions for older adults, they have relied on things like broadband. And I was like, you'll need to get out to a rural area. They do not have broadband out there. This is not going to work. And so if you live in Colorado, wherever you live, this is a national program. I would encourage you to look up the digital equity, the digital access programs that are occurring at the state level where you live and support that work. Because once we're able to connect these communities, it's going to make a big difference in the lives of older adults when they have broadband, they have the device, and they know how to use it. So this might be a good time to move on to questions. So I want to just put this up for the audience. AgeTech resources in the community, we're all an AgeTech resource for you. This is our email addresses. Feel free to reach out to anybody. I didn't actually ask the panel if I could say feel free to reach out at any time, but now we have their email addresses, so feel free. And then we've listed some national and local resources from the Center for Medicare and Medicaid Innovation down to the University of Colorado, Colorado Springs Aging Center, which is a huge partner for the work that I do in Colorado Springs. Look up these different stakeholders throughout the country and in your local community, because these places are doing good work and they're talking about what makes AgeTech effective and sustainable and a good solution for aging in the United States and in your local communities. So thank you very much to the panelists today. It was wonderful to have you here, and I would open up to questions from the audience.
So I've been starting using ChatGPT to for elder care and the idea of wellness calls and for dementia, Alzheimer's evaluation kind of things. And, so I kind of got some of the basics, and I come from the developer kind of side of things, so I'm kind of coming up from there. And I'm trying to figure out essentially how you can get buy-in from an elder generation into super tech, high tech kinds of things like that. Is that, I mean, if there's just an Alexa on the table, is that too much tech that they're like that, throw that in the trash, or is, I don't know. I guess I don't understand. I don't know enough to ask exactly that question.
I mean, I think you're going to have to test it. It depends on who your market is. But what I will say is there's some good studies. There's some out of Duke. There's been some startups that have come out of Duke Research. And they did research on technology uptake and engagement in elderly populations. And again, this is going to depend on your market and what your technology is and how complicated it is and what your like how you teach them and that kind of stuff. But they have found really good uptake and that they learn pretty quick and really well and that they're engaged. I can tell you, this is just a little personal experience. I'm not on Facebook anymore. It's like becoming the thing that I did a long time ago. I cannot tell you, I walk in the homes of these elderly people and like they're sitting at their counter on Facebook. They're in chat groups with other people that have a similar disease, and they start asking. I was talking to Betty online, and she decided to get a trach and a ventilator, and I don't think I want to get. And like they're bringing up these conversations because they're learning from each other online. You would be amazed, and that is a very common experience for me. And so I think if you walk into it saying, we're going to design for the customer, and do market research, and then build your product for your market, and then hire when you get to the point, hire people that can help you like build an education model. I think that you'll always have some people any age that don't want anything to do with that. But then you'll probably get better uptake than you think. And I also just want to say during COVID, the supplemental benefits in Medicare Advantage are becoming much more age-friendly. And they had a companionship supplement. But during COVID, we couldn't send people out to folks' houses. And so we saw this startup shift and make a virtual companionship model, and it was literally phone calls asking how they're doing. It was wildly successful during COVID, wildly successful. And the seniors loved it, the business loved it, so.
These virtual calls, this is still people.
It was people calling, but there was some sort of screening process that was press this button if you're interested, da-da-da-da, and someone will call you back. So there was some part of it that was automated, but it was a virtual companionship, and that's the first thing that I thought of. There are reimbursement models for this out there, and if I were anybody in this room, I would be keeping my eye on what are the Medicare, because they can't just offer any supplemental benefit they want. So Medicare puts guardrails around that. I would recommend everybody keeps their eye on that because they really are shifting and changing and ripe for AgeTech.
The one thing I'll add to that we've learned is that older adults can really tell when something is made for them versus made for somebody else. And they're very sensitive to having their data shared with others to make others feel better about them, if that makes sense. Sharing with kids and grandkids. We see a lot of resistance to that. Don't automatically assume that every older adult wants their data shared with everybody in their family. I would say worried about sharing, I would say yes. We've seen a high level of data sensitivity. But it's just what we've seen is when an older adult sees something is for me. It's made for me. It's made to make my life better. It's designed for me. It looks like it was designed for me. I'm excited about this. I would not worry about tech uptake at all there. I think that
the UI UX piece of it is all about making it so that it's blind to the back end of it, right? They don't need to know that it's AI that's behind it. They just want it to work. And if your customer discovery shows that you can build something that they will enjoy, they'll buy it. They'll use it.
And I would say that goes for every human. Because I went to Lowe's to buy a drill, and they asked me how my husband was going to be using it. And I was like, oh, snap, that's not what's going on here. So I would say, it's true for everybody, right? If someone was selling me a healthcare product so that my mom knew if I was eating the right food for breakfast, I'd be like, I'm not taking this. I don't want your product. So designing for the person, truly for them, is really good advice. And also, I say this sometimes, and it is tongue-in-cheek, but all babies are the same, and no older adults are alike. Because babies need 3 things. And I have no children, right? I just admitted this, so I don't actually know. But babies, they want a clean diaper, they want a warm bed, they want someone to hold them, they want something to eat, right? But the experiences that we have throughout our life make for wildly different market groups for older adults. So we did a tech training with older adults in Colorado Springs, and we had adults in their 50s who had never used a computer in their life. And that was this spring. People in their 50s who had not used a computer at work, had never owned one, didn't know how to get onto their internet or their email, didn't know how to log into their email. So it's not just about your age, and I think we need to take that out of AgeTech, which I know the word age is in AgeTech. But really what we're serving is aging, not an individual's number that's hanging over their head when we're thinking about designing.
I just want to add to that, and I know we have got more questions. Really quickly, just to take not a contrarian point of view, but just my take on it, don't design for older adults. Design with them. Don't infantilize them. Don't say that, I'm a tech person and I know what's best for you. You need to share that with them, and you need to co-create something. It's not one size fits all, it's one size fits one, I think. And I think that there's a really good book that you can buy on Amazon called Designing User Interfaces for Older Adults. Probably should be with, but it's a really good book. It's a textbook. They go through TurboTax and things like that. It's how did they design this? And it's not design friendly things for older adults. It's universal design principles. When you design for for aspects of universal design, it doesn't just benefit older adults. It benefits literally everybody. When something's easier to use for an older adult, it's easier to use for everyone, regardless of age.
In the back.
How would you all think about the role of longevity technology within aging technology? I kind of think of them as a little bit different, and it seems like longevity right now is kind of the purview of a lot of young biohackers, but it hasn't really made it into the aging tech space, things like caloric restriction, rapamycin. How do you kind of think about that, and how might you move that into the realm of aging tech a little more?
I'm the wrong person to ask that question to, because I don't like the term longevity. I don't want everyone to live to 100, because if they did, Medicare would go bankrupt and everyone would die with Alzheimer's.
They're just going to increase our payroll tax.
It's going to cost everyone money. It's going to create, I think, a huge burden on families, right? I believe in really, this is about health span, not lifespan. It's about how well you live, not about how long you live. That's my hot take on that.
They have a saying for that. It's about quality, not quantity.
Oh, that's a palliative care saying right there. I would say, to be honest, I'm going to give you my knee-jerk reaction. I am a hospice and palliative care doctor, so I don't get exposed to the longevity stuff. But I feel like we're already dealing with that right now. When I finished residency, the average life expectancy of somebody living with a heart failure was about diagnosed with heart failure was about 6 to 7 years. I don't even know what it is now. But I can tell you, people are living longer and longer. So we've already seen what that does to healthcare. I mean, I'm fine with people living to 100 if they have a good quality of life. Part of the issue, what we're dealing with, is people are living longer, sicker. And our healthcare system, we have a legacy healthcare system that was designed for people that when they get sick, they die. And that just doesn't happen very often anymore. I mean, anybody follow the news about cancer survival and these cancers that used to kill people, just aggressive cancers, and they're literally going into remission now. So it's about living well for as long as you can. And so part of me is like, yeah, I'm always gonna have a job. I know, that's awful. That's awful. God, you're such a bad influence on me. But anyway, he was to my left, I don't know. But what I would say is, I don't know how those two things come together, but one of our other physician sayings is, history is the best predictor of the future. So if these technologies help people...
Except in financial markets.
Yeah, I'm a doctor. I was talking about clinical stuff. But I would say that look at what's happening right now, and the goal really needs to be not living longer at all costs. I've seen what that looks like, I promise you. I've built consultation services in tertiary, quaternary level hospitals. Okay, so I've seen what that looks like. Having said that, if longevity medicine or biohacking, whatever it is, if that helps people live well longer, it's actually could decrease the cost of healthcare. So that was my major reaction.
I would recommend the Blue Zones documentary to anybody who has Netflix. Has anybody seen it yet? Have you watched it? I've read the book. Yeah, it's very good, and it talks about that. It talks about living longer is about living better. It's not about the metrics, but thank you guys for the feedback on that. Any other questions? Yeah, Joanna.
So I totally can relate to what you're saying about getting shut down in COVID. I do have, as you know, a hardware product. And my question is, and this is really for you, as you look for new products and with so many different, there's every week there's a new event where you could go find new products and see what they're doing. And are there specific events that you find of higher benefit to you as an investor and someone who's more focused on aging, like Leading Age, or there's American Society for the Aging. There's so many health tech events. Where would you say that you see the majority of products or services that you'd be interested in?
Sure. Thanks for your question. I kind of take like a two-level approach to this. One, I think it's good to go to one like big national conference a year. Historically, for most healthcare investors, not companies, it's been JP Morgan, but no one goes to JP Morgan anymore. I mean, tens of thousands of people do, but no one goes to JP Morgan anymore. They go to Health, which is HLTH. It happens in Las Vegas, unfortunately, in a couple weeks. And it's a great place to meet other investors, meet other founders, meet potential partners, and stuff like that. And they've created a really interesting format where you can just schedule meetings with like in funding founders, with like investors and founders and things like that. And it's just a great place to meet people, and people show up for it. So I like going to Health, but I also really like going to more like local events. So I think I'm like the one person here who's not from Colorado. I live in San Diego. But like I like going to events that are kind of local to Southern California, because that's where I can meet some really interesting senior care providers. And I like, it's good to know people at Optum and Humana and, like the big health plans. But a lot of times, like the way that we create value for companies that we invest in, or companies that we just know and, and we want to see what we can do to help them, right? Like we're going to make introductions to their would-be biggest customers or distribution channels or what have you. And so a lot of times it's health plans, right? We're all up here, we're talking about health plans and Medicare, et cetera. So with that said, what I've found is the smaller Medicare Advantage plans, the ones that, like the little local ones, not even like in Intermountain where you worked at Intermountain, but I mean, I met this guy, the CMO of an MA plan. He lives in San Diego. Unfortunately, he's moving back to Massachusetts, but he is CMO of a MA plan called Mass Advantage. They operate in one zip code in Massachusetts. I was like, you're the perfect person for me to know, because what I've learned from talking with people like him, and I met him at like a local event. It was kind of like a healthcare meetup, and then there's another one where it's like health plans in California, right, where you can go, is the smaller players, right, whether it's home health or hospice or a health plan, they have to play the same game as the big guys, but they play it in a different way because they don't have the same balance sheets, they don't have the same access to capital, they don't have the same amount of members or customers or whatever. But that means that they have to be more creative. And that means that actually it's a lot easier to get to the decision maker when you meet them at like a little local conference there, versus, I know someone at Optum and you make an intro and it's like sending this, young company into a black hole, and you're like, I don't know if they ever connected with them.
They tend to be more mission-driven too, and then there are nonprofit health plans out there too. That's the other thing to consider, that tend to be more mission-driven, and these more local regional payers, they tend to be more held accountable by the community too, and closer partnerships with like senior living centers or nursing homes or the hospitals or rehab facilities. So they tend, like their market teams will have closer relationships with the care delivery teams out in the community as well. Like they'll have worked with somebody on the market team at a payer, like their operations person, for 15 years. They'll have had a relationship where they'll see each other at the park and that kind of stuff. So I experienced a little bit of that dynamic working at a regional payer. So take that into consideration too.
actually out of time and they might come kick us out. So sorry to cut off. We had a couple more questions. Feel free to come up and ask our panel if you are able to stay and kind of chat with people after. Thank you so much for coming. I'm really excited about AgeTech. I know that when we get it right, it's going to make life better for all of us and the people who we care for as we're all getting older together. So thank you for coming. Thank you, panel. Have a good day.
Thanks, Aaron.